And so bear with me. We're gonna try to fly through this. I'm not gonna go into a bunch of statistics. And we're assuming that everybody already knows what a labral tear is, right? Everybody knows what FAI and osteoarthritis is. We're gonna go right to, you're gonna walk out with things that maybe some of it's review, maybe you picked up a few new clinical things you could do, but the focus of this is what can our clients do at home to help us help them? And it's not gonna be what we're doing to them in the clinic. So I'll go on a couple of tangents here and there, and feel free to ask questions, during it if you want to. That's fine too. All right, so there's many different kinds of interarticular pathologies, but the ones that we see the most often, OA, big problem, right? There's about 30 million of us in the U.S. alone right now with some amount of personal disability, and we know that's going up big time, all the time. Baby boomers, obesity rates. And just, the expectations too of people, we see 35-year-olds getting hip replacements, we see 40-year-olds. It's kind of interesting. So people have higher expectations to stay active and get active. And what happens is, we've all heard this, the person will go to the surgeon, we find out they have a hip problem, send them to the surgeon or send them to the doc, or they go there and the surgeon says, yeah, you definitely got a big problem, but you're I don't know, 3 years away, you're not bad enough for surgery yet. And they're like, oh, great news. And they're like, okay, so what are we gonna do for my pain and limitation now? Well, there's nothing we can do. There's no cure. Well, what about therapy? Well, they can't do anything for arthritis, so why would you go there? And this still gets told in 2016. It's kind of crazy, right? And so the doc says, well, here's your Vicodin or your NSAIDs, here's your, why don't you lose some weight, Mr. Johnson? You need to lose about 10 pounds. Okay, great. They're motivated and start exercising more, great. They go to exercise, and it just hurts. It just hurts them more. And a normal person, they feel pain, like, well, that must be bad for me, so I'm gonna stop doing that. And then what happens then? It's just that downward cycle, depression, inactivity, social. It's a big problem. It's a really dramatic problem. And everybody knows somebody's had a hip replacement who has some kind of hip problem. Now we have FAI and labral stuff that all of a sudden came out of nowhere, right? They've never existed in the human race before until the last 20 years. But we're just better at, now we know it's not a growing strain for 6 months anymore, right? There's something else going on. And so with this presentation, every one of these topics, we could all talk for 20, 30 hours. So these home manual therapy techniques are good for anything, except there's going to be a few things that should be obvious that you have to tweak a little bit. And we'll kind of go through there. But we're going to think, don't worry about the pathology, just how do they present? What are their impairments? Let's get back to the meat and potatoes of things. All right. I only have 50 minutes left. All right. All right. We'll fly through this. There's so many presentations. One thing you see in the literature, all right, we took these people and they have moderate hip OA. Like, what does that mean? That's like 50,000 different presentations. We're in the trenches, and we see that what the x-ray shows is not how they present clinically, and it's just all over the place. So again, you're gonna have people that have, if you have moderate severe OA, you already have a labral tear, but obviously the OA takes precedence. You're not gonna treat them like they have a labral tear. But if you have a 19-year-old dancer who's super mobile, hypermobile, with a labral tear, you're not going to treat them like you are somebody with moderate OA. And that should be pretty obvious to all of us. So when we get there, we'll kind of talk about, do this except for that 19-year-old. You're not going to want to do it to them because you're not going to injure them. You're just going to make them really mad at you. So, and then how do we know where to start, how fast to progress, and how far they can, where can they get to? It all comes back down to that evaluation. It doesn't matter, labels are labels. It doesn't matter the name of what they have. Nowadays we don't tell them, well, what's my diagnosis? It's like, well, here's your problem list, right? That's how we treat people nowadays. So we want to, what are their impairments, how they present? And so go back to basics. If somebody comes with all this pathology, just can they move or not? What's their range of motion? Would you start them with a lot of strengthening if they can't move? Well, no, you probably say, well, what's good at doing bicep curls from here to here? Let's restore range of motion. And so you know where to start based on how they present to you. And then the progression, we'll talk about this a little bit more, but how fast can we progress them? Some people will come in and you can just crank on them and you're thinking, oh, this person's gonna be so mad at me tomorrow, and they call you and they go, that's the best I've felt for 2 days. And another person, you barely touch them thinking, oh, they're probably not gonna come back because they're disappointed with their treatment. They're in a wheelchair for 3 days. You're just like, what in the heck is going on? So, you gotta get to know them psychologically, socially, what's their experience in the past, what's their pathology. And I always tell people, I'm gonna be really boring for 2 visits. but don't worry, I'm going to try to kick your ass as fast as I can. Especially with the athlete. The athlete comes in, if you don't tell that to them and they're really bored, they're not going to come back for their third visit thinking, this is how it's going to be for 6 weeks, this is lame, right? So I kind of hit them with both those sayings of, be really patient with me, be patient with your own body. I hope that you find me boring for a couple of visits, but you're going to find me really exciting soon enough. And once they know that going in, that really helps them. All right, and we'll cover a little bit more about this too, is, when it comes to steroid injections and surgery is the gold standard for hip OA or for these hip problems, if they're appropriate for it. But you want to exhaust their conservative measures first if you can. Now, there are lots of situations where you may not do that. You may have that single mom with 3 kids who can't sit there and kind of pound away with you for 3 years trying to figure this out. And they just got to get to surgery prematurely maybe, and that's okay. So there's a lot of factors, psychosocial and economic factors that go into this. But basically we want to make sure, that's the one thing I love. A lot of people will ask me, like, why are you such a glutton for punishment? Why do you like treating incurable hip problems? That can't be any fun. But for me, I'm 100% successful, and everybody in this room is too, depending on how you think about it, right? I sleep fine at night, no matter what happens during the day, because you can't lose. You can't lose treating incurable things, because if somebody comes in with a 7 out of 10 pain level or whatever, right, and they're not active, and they're angry, and then they tell you 2 months later, how are you doing? Well, now I'm a 4 out of 10, I do yoga twice a week, and I've been walking with my wife, and you win. You just won, right? Because it depends on what the goal is. You got to tell that person, I'm not going to cure what you have, I'm not going to stop you having surgery. If you live long enough, you'll probably have this surgery, and that's another conversation. You don't want to go too far down that road. You got to set the goals and expectations for people. If somebody has mild OA, and we see this all the time. What I love about my job is, our job is those teary-eyed hugs you get at that last visit. Those emails, and thank you so much for making my hip pain go away. I can't believe you cured my OA. I'm like, actually, it's worse today than it was 2 months ago, probably. But anyways, it all comes down to setting expectations and education and just talking. I think one of the biggest fail points for providers is they just don't take the time to dig in and talk a little bit and really make sure that person understands. So I treat every one of my clients like I'm their CI and they're my student. They are going to be a physical therapist by the time I'm done with them. I think that's important. And by the way, on steroid shots, big fan of steroid injections for this part of the body when it's appropriate. Not a big fan for adding steroid. Just it's not like water. I don't want steroids in everybody, but man, it's so great when you have somebody come in with a hot shoulder or a hot hip like this, and you can't even do long axis traction. You can't even touch them. You're just going to be wasting their money and time. Send them right back to the doc. Get a steroid injection. It just unlocks that sort of pain cycle, so you can get in there and start playing around some more. Or especially important when you've been working on them, right, and they have that big trip to Hawaii or Europe. They've been in pain for so long, they just want to have some fun. Get them a steroid shot 2 weeks, 10 days before that trip, and they'll just have a great time. You'll deal with the ramifications when they get back. But I think steroid has a great place in this situation, and so, but it's the same with frozen shoulder too. They have a really mad shoulder. What are you going to do, right? You gotta get it calmed down so you start working with it.